The next speaker we have is Janet Way, who is a faculty cardiologist and cardiac imager, as well as in the biomedical sciences department. She's the co-director of the stress echocardiocardiology lab at Cedars-Sinai, and she will be talking to us about multivascular bed MR vessel wall imaging in MI patients.
Thank you so much. And I have to say, as a cardiologist, I've been so inspired by all the talks today, particularly about all the exciting technologies and how we can potentially implement them more often in the clinical care setting. This is my disclosure, not relevant to this work that I'm going to be presenting. So the work that I'm going to be presenting is related to an NIH Career Development Award that I've been working on this past couple of years. I'm going to be presenting you data that we've collected at Cedars-Sinai and is not published, but we are very interested, of course, in the concept that you've all discussed today, was the idea of using imaging as a way to understand risk in patients. Of course, I like to be able to apply it in a general population, but trying to understand which populations are going to be most beneficial for this type of technology. Today, I'm going to be talking about our attempt to look at polyvascular vascular plaque, and we know that multiple studies have shown that when you have plaque in multiple vascular beds, that's actually associated with an increased risk of cardiovascular events compared to just having plaque in a single vascular bed. And now with novel MRI techniques, as you are all aware, that can identify adverse plaque features that are rapid, are reproducible. This makes polyvascular bed atherosclerotic phenotyping potentially more exciting and feasible. At Cedars, we started this project before QMatch, so I'm not talking about QMatch, but Match, where we are able to use these technology to understand both plaque burden, to look at intraplaque hemorrhage, and the protocols that we're going to review is based off of this original Match sequence, where we're going to be looking at the hyper T1 images, the gray blood, and then the T2 weighted images. Similarly, on the coronary side of things, we've also been using a sequence called CATCH for coronary atherosclerotic T1 weighted characterization, where prior work by Dr. Yibin Xie as well as Dr. Debiao Li and team have correlated these hyperintense plaques with intravascular imaging of increased risk factors, biomarkers that are associated with large lipid pool, macrophage clusters, cholesterol crystals, which we think are related to coronary intraplaque hemorrhage. In addition, the addition of the gadolinium enhancement and imaging them, 20 to 30 minutes post-contrast, a question of can we understand this type of plaque morphology as presence of inflammation or other sorts of vessel remodeling. And so that's what we will be talking about today. There have been other groups published very interesting findings in clinical trials of this intraplaque hemorrhage. You heard that it's really a leading biomarker for understanding risk, and also this trial called the AQUAMARINE pilot study, where the Japanese group found that being on a high-intensity statin demonstrated reduction in PMR intensity for these high-risk plaque features. And those who did not take a statin, actually there was a relationship with increased plaque progression as well as this higher PMR intensity difference. So again, potential clinical applications for this technology. And then in terms of the late kind of gadolinium hyperenhancement, an older study showed that serial contrast imaging of coronary wall hyperenhancement after acute MI was able to be distinguished from those who had the prior MI versus those who had no obstructive coronary artery disease. And you can see in these different examples here in the first line, there's a patient with normal-looking right coronary artery with no evidence of enhanced contrast. Vessel wall imaging, and then with some mild coronary artery disease, you can see some enhancement on that T1 weighted 3D IRTFE in the third column there. But then the patient also had evidence of this enhancement in other vessels as well that were not necessarily culprit vessels. So a lot of interest was kind of garnered from this potential application, although there's not much clinical application at this time. So my question for the study was, can we perform concurrent vascular bed atherosclerotic phenotyping in the coronary and carotid beds in patients with a recent history of myocardial infarction and stroke? My inclusion criteria were men and women with a recent MI or ischemic stroke or TIA within 1 year, excluded contraindications to MRI, as well as other factors that would make it difficult to image this patient population. Also wanted to focus on ischemic stroke and also excluded those who were felt to have a cardioembolic origin. So this was the MRI protocol that we used, starting off with the catch sequence, followed by carotid imaging, contrast given. We used Gadavis 0.1 millimoles here, and then followed by coronary imaging for post-contrast vessel wall evaluation. We have recruited about 27 patients with prior MI, 17 patients with prior stroke, and you can see some of the baseline characteristics there. A majority of patients with the prior MI were on statin or other lipid-lowering therapy, although you can see that it was lower in this stroke cohort. About over half of them did have a 1-year follow-up MRI, because I was interested in also looking at whether it was feasible to look at changes over time on the therapies in this cohort study. And here in this table, labeled coronary hyperintense plaque, or CHIP, to kind of represent the intraplaque hemorrhage, and then contrast enhancement, or CE, in this table. Overall, only 3 of our 27 participants had a hyperintense plaque that was felt to be consistent with intraplaque hemorrhage. That was about 12%. But we did have a large proportion of patients who did have evidence of contrast-enhanced coronary vessel wall at baseline. Interestingly, those who had coronary enhanced vessel wall at baseline, they continue to have the presence of enhancement even at 1-year follow-up. And then those who did have the hyperintense plaque felt to be IPH, we actually did not see that on the follow-up imaging, but there was only 2 patients who were imaged of those original 3. And so I think this just kind of raises some potential ideas, to try to understand, could we use this information to help guide further studies to help us understand risk as well as, potential therapeutic interventions. I just wanted to share, some case examples of our participants. This was a man who actually had a left vertebral artery stroke and was recruited for the study, and his coronary arteries didn't show any obstructive lesions on our bright blood imaging. On the pre-contrast T1 catch images, we did see this hyperintense plaque in the proximal right coronary artery with a PMR ratio of 1.72. And this patient had no, cardiac symptoms. And then on the match sequence, we did see that there was non-obstructive plaque in the left internal carotid artery. And then you can also see below that there's the occluded vertebral artery. But most, surprisingly to me, there was also the hyper T1 intensity in that left carotid artery that could be the intraplaque hemorrhage. Another patient that we had who had a right coronary artery ST elevation MI had an occlusion of the proximal RCA. This was the angiogram prior to stent placement on the right. The red arrow shows the occluded right coronary artery. The patient also had a prior occluded left circumflex area represented by the red arrow on the right image, some non-obstructive stenosis in the diagonal artery, and then just kind of diffuse disease in the left anterior descending artery represented by the blue arrow. And on the post-contrast catch images, this is just an example where we did see that there was enhancement of the distal left anterior descending artery, although it was not present in the other vessels. That questions again, could this be a representation of inflammation or some sort of fibrosis, vascular remodeling? This same patient with the RCA STEMI did have Dante space sequence for carotid MRI imaging and showed some non-obstructive plaque in the carotid bulb, the proximal left internal carotid artery, as you can see there. And then on this image of the match sequence where we're first looking at the black blood imaging, followed by the gray blood imaging, which we're trying to look for calcifications, then followed by the hyper T1 imaging. Again, very surprised to see in this otherwise no prior history of TIA or stroke patient, this suggestion that might be consistent with intraplaque hemorrhage. In a separate case of just kind of showing another chip hyperintense plaque in the distal LAD where the PMR ratio was a little bit lower than the prior example of 1.29. And again, this was someone who already had prior MI a year ago, and that did show this hyper enhancement. In the challenge of these patients who have stents in their arteries are, how can you distinguish if there's an artifact or if there's a true hyperenhancement? This is just showing that we can visualize that gray hypoic lesion representing the stent in the mid-LAD. But then if you just kind of gradually go proximally away from the stent, we actually did see post-contrast enhancement of that LAD. And again, we don't know all of the clinical significance of this hyperenhancement, but very interesting that it is not consistent in all vessels and certainly not in every patient. From learning about scanning these patients, one of the attractions of doing MR to begin with was, wow, I could do this very quickly and patients will get a lot of information. But, as in clinical practice, sometimes things don't always go smoothly. We have patients who are obese, who have obstructive sleep apnea, and the navigation is hard to control. There's patients who have, of course, sometimes arrhythmias. And I'll have to put in a kind of marker that we did initially want to scan the femoral artery. There was a question about femoral artery disease because my initial goal was to actually image all 3 vessel beds, but it was just taking such a long time that we had to drop one of the images. And because our patients generally did not have much plaque in the femoral bifurcation, we opted to drop that. But future steps that I'm currently undergoing is for more quantitative measures of the carotid plaque and hopefully learning more from this group here about the machine learning. And of course, the tracing of those per segment analysis takes a long time, trying to understand how we're going to measure the average signal ratios versus kind of the peak contrast noise ratios. And then also trying to see if this is really something that's real, when we compare baseline and follow-up. But I wanted to thank everyone for allowing me to present some of this preliminary work and appreciate all of the support that I've had from my mentors in the Biomedical Imaging Research Institute, as well as members who are here today. I remember when I was a early instructor, actually listening to lectures from Dr. Yuan just about the intraplaque hemorrhage and all the great work that's being done from all of you. So thank you very much.